Hello, it's a pleasure for me to discuss clinical perspectives for the individual patient and the community. These are my disclosures. Personalized medicine has become very popularized by celebrities such as Angelina Jolie talking about her BRCA mutations and Beyonce talking about her father's male breast cancer. Why is mutation status important in prostate cancer? Well, we know that if we take 692 unselected men, 12% of them may have presumed pathologic DNA repair germline mutations. That is by looking at their blood and looking at their germline in all of their cells. This is important for the patients and also for their families as well. If we look at the genomic alterations in the tissue of metastatic castration-resistant prostate cancer, 90% of metastatic castration-resistant prostate cancer harbor clinically actionable molecular alterations, and 20% of metastatic CRPC harbor DNA repair pathway alterations. And homologous recombination DNA repair requires multiple proteins. It's not just BRCA1 and 2. Loss of many DNA repair proteins can also generate the same kind of phenotype as BRCA-ness. Defects in DNA repair genes are associated with PARP inhibitor sensitivity. We knew this first from the TOPARP-A study, where 49 heavily pretreated men with metastatic prostate cancer were treated with the PARP inhibitor olaparib. And what we saw in this study was that 16 of these patients had genomic abnormalities in their tissues. And what they saw was that 14 of the 16 who had these abnormalities, such as BRCA2 or ATM or BRCA1, had a response rate that's some 80%. And if we look at the radiologic progression-free survival and the overall survival in these patients, those with the biomarker did much, much better than those without. This was work done by Johan Dubono and Matteo at the Royal Marsden. And again, the same group did the TOPARP-B study, again, looking at the same DDR, DNA damage repair genes, including many that you can see here listed on the screen. And you can see here by this waterfall plot of PSA 50 threshold that the ones who responded the best are the ones who have BRCA1 and 2, but that others with ATM and CDK12 and others also can respond to olaparib therapy. This led to the PROfound study for metastatic CRPC for patients who have progressed on a prior novel hormonal agent such as abiraterone or enzalutamide, and they needed to have alterations in at least one of the qualifying genes. And these were primarily somatic alterations, but germline mutations also could have been included. The cohort A included BRCA1, BRCA2, or ATM. This was the largest cohort. And then there was a cohort B of all homologous recombination gene-related genes, as you can see listed on the bottom. Patients were randomized between receiving olaparib 300 milligrams twice a day or physician's choice of therapy, be it abiraterone or enzalutamide, depending on what they had received previously. The primary endpoint was radiographic progression-free survival in cohort A, the BRCA1, BRCA2, or ATM cohort. You can see from this trial, the primary endpoint was met looking at the radiographic progression-free survival by blinded independent review in cohort A. There's a clear difference in progression-free survival. And also, if we look at the entire cohorts combining A and B, again, this a secondary endpoint, there is a difference in progression-free survival by blinded independent review. And if we look at the cohort A alone in this trial, there's an improvement in overall survival, even though the majority of patients in the non-olaparib arm eventually were given olaparib to crossover. And you can see at the bottom slide here of the slide, the crossover adjusted for the patients who crossed over. You can see quite a difference and improvement in overall survival. Well, these are the NCCN guidelines if you look at them, all of them are category 2A, and they recommend for patients with regional disease, any T, N1, or M0, they recommend molecular and biomarker analysis of tumor. They recommend consider tumor testing for homologous recombination gene mutations and for microsatellite instability and or mismatch repair deficiency. They recommend germline testing. And for patients with metastatic tumor, with any T, any N, M1, again, germline testing is recommended. And for the tumor, they recommend tumor testing for homologous recombination repair, and they consider tumor testing for microsatellite instability or mismatch repair. Now, we know that the majority of patients where we're going to find germline defects are those with a family history of multiple family members with prostate cancer less than age 60, those of Ashkenazi Jewish ancestry, those with a family history of BRCA1 and 2, or in patients that have had 3 or more cancers on the same side of the family that occurred at less than age 50. And in these guidelines, they also say that genetic testing is for high risk, very high risk regional or metastatic prostate cancer is recommended mostly, and the genetic testing in the absence of a family history or high-risk cancer may be of low yield. But nonetheless, these are the most recent NCCN guidelines. Now, the ESMO guidelines were published in 2020. The guidelines do not have a 2A recommendation. The recommendations are 4C or 3B, but they recommend tissue-based molecular assays may be used in conjunction with clinical pathological factors for treatment decision in localized prostate cancer, germline testing for BRCA2 and other DDR genes associated with cancer predisposition syndromes recommended for patients with a family history of cancer and should be considered in all patients with metastatic prostate cancer, recommendation 3B. Consider tumor testing for homologous recombination genes and mismatch repair or microsatellite instability in patients with metastatic CRPC. Patients with pathogenic mutations in cancer risk genes identified through tumor testing should be referred for germline testing and genetic counseling. Olaparib can be considered after new hormonal agents for patients with metastatic CRPC with alterations in BRCA1 or BRCA2. Now, there's a huge variability across countries in genomic testing and in clinicians' understanding of prostate cancer. I spoke to Elena Castro, a geneticist in Spain. She felt that most oncologists and urologists in Europe and in Spain are aware of the importance of implementing precision medicine for prostate cancer. Most European, national, and local conferences include sessions dedicated to these topics, and clinicians understand that this is something that will happen, but outside academic institutions or clinical trials, most people are not sequencing tumors. In different parts of the EU, there are several reasons. Clinicians' understanding of prostate cancer genetics, genomics, plasma tissue testing, et cetera, is variable from one person to another, but it seems that colleagues treating other tumor types, such as lung cancer, are more knowledgeable of these aspects. It'll take some time, but local scientific societies should invest in educating non-academic clinicians that often care for a very large number of patients. I spoke to physicians in the UK. Chris Parker was one of the authors of the ESMO guidelines. These tests are not being done routinely by the National Health Service. They're being done for the purposes of clinical trial eligibility and in private practice. And he said that it was safe to assume that the large majority of patients do not have access. Johan de Bono, on the other hand, at the Royal Marsden, they are sequencing tissue samples within a screening protocol, Maestro. They use the targeted customized panel of 133 genes that was validated in the TOPARP A and TOPARP B trials. And Tom Bowles, also in the UK, said it's very much driven by need. As soon as there's a personalized drug that's available, the facilities to do the tests need to be accounted for. When drugs are approved, as have occurred in lung cancer, for ALK, for instance, things need to be centralized, and universities have attempted to do this testing. Giuseppe Bana, who worked also for years in the UK, says that there are 6 regional genomic hubs that have been set up in England, and they have started doing next generation sequencing according to some predefined panels. Those are, of course, related to licensed or almost licensed drugs. In March 2021, it was announced a 1-year free access to the Garden 360 NGS liquid and solid biopsy for all patients within NHS England, based on individual agreements with each trust and the definition of a molecular lead for each trust, but nothing has started so far. Of course, for familiar cases, they can refer to regional genetic counseling analysis. Again, in Spain, only olaparib has been approved by EMA and only for BRCA1 and 2, and it's still not reimbursed by many public health systems, for example, in Spain. So if you can't use the drug, why bother testing for it? Although most centers have access to certified labs, tumor testing for metastatic prostate cancer is not reimbursed in most countries or most regions in Spain. Besides, non-academic institutions will have to outsource the NGS. And in the meantime, some pharmaceutical companies are planning to offer testing for a period of time, as they have previously done for ovarian cancer, when they have a drug that's approved. At present, most clinicians are still not offering germline testing to their patients. One of the reasons is the shortage of genetic counselors, but also because in many places it's still undecided how will patients be counseled pre-test by the geneticist or by the urologist or by the oncologist, and all this needs to be worked out. In Italy, Pasquale Orsegno spoke to me. He said that despite the imminent approval of olaparib in prostate cancer, there is not a national agreement on how and what to sequence in Italy for prostate cancer patients. Many clinicians are asking patients to pay for a foundation test using either tissue samples or blood ones. Recently, the Italian Society of Medical Oncology guidelines have suggested to get tissue and blood sample tested for all patients with advanced prostate cancer in case of an identified mutation, then to receive genetic counseling for germline testing. There's no recommendation on which tumor sample is better to use, blood, tissue, or which to perform. For germline testing, instead, there is a hub in Piedmont and in some other regions for the identification of BRCA1 and 2 mutations, but this has mainly been for breast and ovarian cancer patients with a positive family history. Internally at Hospital Candiola, they're using a targeted panel. The problem is that implementation in clinical practice and accessibility to molecular tumor boards is still limited in Italy, as shown by a recent Italian Society of Medical Oncology survey, that according to which only 13% of oncologists can rely on these multidisciplinary teams in their facility. Again, in Italy, Dario Trapani told me that they use Foundation One more commonly, but it's not reimbursed by the Italian health system. Therefore, they can only use it for some diseases, including prostate cancer, in the context of molecular epidemiology registers or clinical trials. Otherwise, the patients have to pay. For prostate cancer, they're able to request BRCA in the concept of a family risk, as indicated by national guidelines. Also, recently, the Public Health Service has added the somatic BRCA determination as possibly reimbursed. For all tumors, including prostate, they are also able to determine and is reimbursed the status of microsatellite instability for the agnostic use of immunotherapy. However, tumor mutational burden is not reimbursed, nor is there an indication for immunotherapy based on the Italian Agency of Pharmaceuticals. So they reimburse single tests like BRCA, somatic BRCA, and MSI, but not next generation sequencing in Italy. I spoke to Karim Fizazi and Giulia Vaccarello, who worked with him at the Gustave Roussy in France. They have a panel for non-small cell lung cancer across the country, and for KRAS for colorectal cancer, and for classical ER, PR, and HER2 for breast cancer, and for DDR genes for ovarian and pancreatic cancer. Genetic consultation is needed. Germline testing on all men age less than 60 with high-risk prostate cancer and a family history or metastatic hormone-sensitive prostate cancer is recommended by international French guidelines, and all of the above, according to Dr. Fizazi, are covered by their national health system. Somatic tests are not reimbursed, and they try their best to put patients in academic clinical trials so they can get these tests done. Others, when the benefit from doing the biomarker is not fully established, either it's not done routinely or it's covered by hospitals or different academic grants. I spoke to Axel Heidenreich and others in Germany, and with regard to genetic or molecular testing, in Germany is still in its infancy, and only a minority of institutions perform routine testing. Very few people stick to NCCN guidelines with regard to genetic testing, and although olaparib has been approved in Germany in February 2021, very few people perform molecular pathology due to reimbursement issues. Since the approach differ significantly between institutions, Dr. Heidenreich, who is the chairman in Cologne, was kind enough to show me that in his own institution, they are doing quite a bit of genetic testing. That's too much to go into, but I wanted you to see this slide. And I think it's really variable among different universities and probably much less so in the community. Obviously, Sela in Israel told me that there are at least 6 companies that offer genomic testing. Most check DNA repair genes after androgen deprivation therapy, and 1 novel androgen receptor inhibitor, sometimes before chemotherapy. PARP inhibitors are not yet approved in Israel, but they are on discussion for next year. Well, in New York, we have New York State approval for what we call Oncomine, and this is part of our testing of tumor tissue, which is tests 140 genes, and we normally first use Oncomine through our pathology lab, and then in certain cases it had been experimental only in precision medicine, but now it is no longer done in precision medicine. Is the exact one test doing that it evaluates 22,000 genes, and we've now developing a new, we hope, better test called Exact 2, and we participated in the NCA match trial of precision medicine, which is agnostic to tumor type, depending on various genetic abnormalities that are found. I spoke to Heather Cheng, who is a geneticist at the University of Washington, and she said they are currently getting somatic testing for metastatic disease and sometimes for biochemical recurrent patients, and a good proportion of NCCN eligible patients, including high-risk localized and node positive, are being offered germline genetic testing, although not all patients proceed. The only experience that she has with the community is from the referring physicians and the patients who are transferring their care, and there's an increasing proportion that seem to be getting tumor or germline testing through a variety of different private companies, although she's somewhat skeptical of the results depending on the timing and the disease status at the time of the testing. For germline testing, there's a fair amount of testing being done in the United States, but insurance does not universally cover this either, but companies may have some mechanism by which it's covered under research or patient assistance. My hope is that with liquid tumor biopsies in the future, we will be able to measure circulating tumor DNA, circulating tumor RNA, and we'll be able to get a lot more information and not have to do continued biopsies of metastatic disease to understand our patients and their genetic profile. And I think that this will be in the very, very near future. In terms of conclusions, NCCN and ESMO guidelines encourage genomic testing. There's a huge variability across countries in access to genomic testing. It's likely that there's also huge variability in the testing methodology itself in different centers. There doesn't seem to be enough oversight to validate all of this testing. Many countries do not offer genetic testing, and it's not reimbursed. As more drugs are approved, individual tests will likely be more frequently offered. There's a lack of genetic counselors. Increased implementation in clinical practice and accessibility to molecular tumor boards will be our hope for the future. Thank you very much for your attention, and thank you to all of you who helped me to prepare this presentation. Thank you.